Hi, and want to thank everybody for joining us today for our webinar, Microbiota Transplant Therapy for Inflammatory Bowel Disease. My name is Christy Lansdowne, and I serve as the Executive Director of Achieving Cures Together. For those new to ACT, I'll briefly introduce our organization before our keynote speaker, Dr. Vaughn, here shares with us this evening. ACT was founded 10 years ago by Peter Westerhouse, a patient who battled severe ulcerative colitis. And Peter was the first UC patient treated with microbiota transplant therapy at the U of M under the care of Dr. Alex Koritz, director of the Microbiota Therapeutics program. Following his transplants, Peter experienced remarkable healing throughout most of his intestinal tract. However, he had a small section of high-risk intestine that did require surgery. Just make sure my slide changes here. Sorry, guys. Peter's experience inspired him to form ACT with the goal of advancing research in microbiota transplant therapy. ACT partners with Dr. Koritz, Dr. Vaughn, and their colleagues at the University of Minnesota's Microbiota Therapeutics program to produce microbiota-based therapies that are being used to both treat patients with recurrent antibiotic-resistant C. difficile infections and to supply clinical trials led by academic partners throughout the country focused on a range of health conditions. Through our partnership with the University of Minnesota, we've provided over 65,000 microbiota treatments to research clinical trials around the country and to patients with recurrent C. difficile infections. Today, ACT supports microbiota research targeting infectious diseases, cancer recovery, cardiovascular health, digestive system disorders, which we'll dive into more in our webinar tonight, the gut-brain connection, and immune system disorders. ACT is also fully funding the first year of an upcoming ulcerative colitis clinical trial led by Dr. Vaughn here with us tonight, and we'll hear more about his research this evening. Our mission and work would not be possible without the generous support of our donors who share our vision, so we want to say thank you so much. We will have a Q&A opportunity at the end of the webinar. So please, throughout the webinar, feel free to submit questions in the chat feature, and we'll hold answering those until the conclusion of the initial presentation. It's my pleasure to now introduce our speaker this evening. Dr. Byron Vaughn is a practicing gastroenterologist and associate professor of medicine at the University of Minnesota. He is a leading expert in inflammatory bowel disease and is actively exploring the role of intestinal microbiota in immune regulation and inflammation. Dr. Vaughn's research is focused on improving outcomes for patients with IBD through therapeutic manipulation of the gut microbiome. So thank you so much for joining us, and we'll dive right in. I'll pass it off to Dr. Vaughn.
Thank you so much for that introduction. We'll go through these slides here and then hopefully have plenty of time now to answer any questions, because I always think that discussion and having a little bit of interaction is often more helpful. A few disclosures, some research support and consulting, nothing that really pertains to this talk. We're going to talk about a few overarching view of what it might look like and what it does look like for microbiota-based therapies to be approved. We're going to look at the clinical trial data for microbiota-based therapies in ulcerative colitis and think about microbiota-based therapies for Crohn's disease. So first of all, I think it's helpful to talk and be on the same page about what we're talking about, because there's a few different terms that you might hear. A lot of them are more or less synonymous, but fecal microbiota transplantation, FMT, is what is often in the news. And people hear that and it's kind of got an ick factor, but it's also pretty curious. We are more and more using the term microbiota transplant therapy, even though it's really the same thing. So one of the questions is why the change in transplant to therapy? Is this a transplant? Is this a drug? Well, the truth is it's kind of both. If you think about a traditional organ transplant, you have someone who undergoes donor screening, you select a donor for the organ. You can measure an engraftment, an organ engrafts. For example, in bone marrow transplant, liver and kidneys, those all have to they have to be engrafted into the new host. And an organ transplant doesn't repair just one thing, it fixes a bunch of things. It restores numerous functions. A liver transplant is, the liver does hundreds of things. When you get a new liver, all those functions are restored. So in some ways, an FMT is like that. We have donor screening and selection, we measure engraftment, and there's numerous functions of the gut microbiome, the gut microbiota that we're restoring. It's also in some ways, though, a little bit like a drug. We can dose it based on the number of bacteria. We can do repeat dosing. That's clearly not something we do with a transplant. And there may be more of an immunologic mechanism, a little bit more like a biologic. So it kind of brings the question, is it a transplant or a drug? Well, it's a little bit of both, and it kind of depends on how you're studying it. This is important and challenging because when something doesn't fit into the regulatory framework very well, it sometimes makes it challenging for things to get approved. But for the purpose of IBD, I think it is safest to talk about it in terms of a biologic drug like microbiota transplant therapy. So you'll see that term today, but know that it's pretty synonymous with FMT. A little bit about IBD. This is a high-level overview of IBD. There's a lot of nuance and individual variation. But the fundamental story for IBD is that people have to have a genetic predisposition to start, and there's a number of at-risk genes. In fact, there's over 400 at-risk genes. But clearly, having an at-risk gene does not mean that you get IBD. With very few exceptions, people are generally diagnosed later in life, in their 20s and 30s. So something happens. You have some at-risk genes, and then there's an insult, a trigger, and there's some type of immune dysregulation with your own gut bacteria, and that leads to an overactive immune response against your gut bacteria and your intestine. So that's kind of the overarching framework. All of our existing therapies right now target the overacting immune response in some form. They block immune cells from getting to the gut, they turn down cytokines or the signals that immune cells use. Another way to think about it is that you have genetic predisposition, as we talked about, environmental trigger, chronic intestinal inflammation, and dysbiosis, meaning the gut bacteria are not normal. Here's where our current therapies are, but we really don't have any therapies targeted at the other half of the problem. And that's where we're trying to study things. That's where we're trying to bring in more knowledge and therapies by not necessarily replacing standard of care, but supplementing standard of care and helping fill those gaps, which we'll see some of those gaps later in the talk. So is this possible? Well, in ulcerative colitis, there have actually been 9 randomized controlled trials using some form of FMT or FMT-like product compared to standard of care placebo, or diet. And we see that people who get FMT do better in the short term. This is a pooled summary of all that data, and people do about twice as better in terms of remission of symptoms and improvement of endoscopy. So I think there's clearly something there, especially for ulcerative colitis. Now, there's a lot of variation in these studies. Patients were different. The FMT product was different. Some people got antibiotics, some people didn't. The route wasn't the same. So some people got repeated enemas, other people got colonoscopy, other people got pills. So it's not like this is one product that was being compared. But regardless, it looks like FMT or MTT does have some benefit. So how does it work? Well, a couple hypotheses. One is that it decreases the bad bacteria, also known as dysbiosis, and restores eubiosis, which is normal bacteria. And by doing that, it's possible that that decreases inflammation and/or symptoms from IBD. Another hypothesis could be that engrafting the healthy microbiome decreases the stimulus for chronic inflammation. So that's one of the first things that we started to test. As I was mentioned earlier, I'm part of the Microbiota Therapeutics program, which is at the University of Minnesota, founded by Dr. Koretz and Sadowski. This program, which is in many ways made possible by the support from ACT, is able to standardize a process of donor screening, stool collection, and filtering and dosing that allows these trials to be possible. So we're able to have access to a standardized type of FMT or MTT material in the form of capsules or liquid or powder. And this is essential. We couldn't do any of the clinical research without this. We're going to talk a little bit disease specific now. So looking just at ulcerative colitis. We started our first trial for UC back in 2018 with the goal of looking at how well we could engraft this bacteria into people with UC and look at the safety and tolerability, and also to look at the clinical changes over time. This is our intervention. Capsules. This is what they look like. This is an actual picture we took of our capsules. So they're protected. The bacteria are protected from the stomach by this double coating, and they release in the small bowel and the colon. There's a number of bacteria per capsule, much more bacteria than a probiotic, and also much more diverse. These are that represent the entire intestinal or colonic microbiome. For our trial, we gave 2 capsules a day for 8 weeks without any antibiotic preconditioning or bowel cleanse. So again, there's variations on this, but we chose that path because it was the simplest and what we think is the cleanest, and most likely to be done, hopefully sometime at the bedside. We looked at engraftment and changes in clinical symptoms, which we'll get to. We were not in this study able to look at endoscopy. So if you're familiar with inflammatory bowel disease, you know that symptoms can kind of go up and down, but endoscopy is really important because it is kind of considered the gold standard for improving something. What this graph shows is that using a symptom score it does correlate very closely to endoscopy and ulcerative colitis. So even though we don't have endoscopy, we did use the symptom score, which in general does correlate very well to changes on endoscopy. This is our clinical trial design. So you can, if you're familiar with looking at these, it's a pretty standard one-to-one randomization. So half the people got our therapy, half the people got placebo, which was indistinguishable capsules from the MTT therapy. And then after they completed, after someone got through that first 12-week period, they were offered to open label. They were offered to receive the capsules and just see how they did overall over the course of 8 weeks with another 4-week safety examination. So that's a little bit of background for how to interpret some of this, because I think some of our findings were a little nuanced in this trial design. It was a small study. So our first study for UC was a pilot feasibility study. We ended up randomizing 27 people, 13 got the MTT and 14 got placebo for the first part. A few people withdrew for a couple of reasons there. You can see here that the people in both arms were relatively similar, about the same age, about the same sex breakdown, people with the same duration and severity of ulcerative colitis, some people being not on any advanced therapies for UC, others having failed 2 or more therapies. So a wide range of people with UC. At baseline, there is no substantial difference in their disease activity. Most people with moderate disease, actually just nobody in the study ended up having severe disease, and a few people with mild disease. What did we see? So looking at our clinical response, we actually saw that by week 4, compared to the people who got placebo, there was a dramatic clinical response. 46% of people that got MTT therapy had some improvement, whereas only 7% of people on placebo had any improvement. And that 46% stayed, about half of people had a clinical response over the course of the study. We did see that the number of people in the placebo arm over time crept up. And we think that the reason that happened is just because there is a placebo effect, and over time, some of these symptoms wax and wane. We didn't really see a major difference in clinical remission, but we had a very, very strict definition for clinical remission. It had to be basically the complete absence of symptoms. So that's a little atypical for other trials, but it's notable. Getting into the data for UC in a little bit more, we can look at the individuals compared to baseline. We see at weeks 4 and week 8, while they were taking therapy, had a significant decrease in their symptoms. Compare this to placebo, who had no change at any time point in their symptoms. Now, this is a small study, and small studies are at risk for false positive findings. But remember, this is blinded, so the patients and the investigators did not know who was getting what. So I think this signal is real. When we look at the people who got MTT and then look at again when they got it in open label, because most patients opted to get into the open label extension, we don't see a significant improvement of symptoms, but we do see a trend over time towards an improvement. Now, when we look at the people who did not get MTT therapy in the randomized portion, so again, the same data where for the first 8 weeks there was no difference. When they did enter the open label, they actually all had a significant improvement in their symptoms. So, I think that while you could argue that maybe the first part of the trial it was too small to see a difference and it was just noise, I think the fact that when the people who got placebo actually improved after the fact is a pretty compelling narrative that this therapy is doing something to reduce symptoms. So that was our first conclusion, that the administration of the MTT product led to an improvement in clinical symptoms related to UC. The benefit seems to be the greatest with the first administration, and it may not be additive. It may not have the same benefit, although it's possible we were underpowered to see a difference. So what happened to all the gut bacteria? Well, these are some complex slides. If you're not used to looking at changes in gut bacteria, this may not make sense. But we basically saw some change in the content of the gut bacteria that were there, but it wasn't a slam dunk change. We could see that by one index, the Shannon index, it looked pretty similar. But by another index, we did see that the people who got MTT over time had a benefit in their richness. We also saw that the people who got MTT over time became more similar to their donors compared to the placebo. Now, the placebos didn't really have a donor, but we matched them to an imaginary donor so that we could look at things like engraftment and donor similarity. We see that over time there was a similarity in their microbiome to their donors. And this is another way of looking at it. Basically, this is an idea of measuring engraftment. We essentially saw no engraftment in the placebo arm, which is what we'd expect because they just got placebo. And we see that at around 3 to 4 weeks, we had about 40% of engraftment of the good bacteria into our recipients. So that's encouraging that we had an improvement in engraftment. But did the engraftment matter, right? Or was this just an association? Interestingly, and this was, I thought, very surprising at first, but maybe does make more sense as I've been thinking about it over time, there is really no relationship between the clinical response and engraftment, meaning the people who had clear evidence of shifting towards their donors were not necessarily the ones that got better. This is just two graphs that are showing the exact same thing, that there really was not any benefit to engraftment. So our final conclusion from our first study was that the donor microbiota engraftment does not appear to be the mechanism of benefit in UC patients receiving MTT. So next steps, we need to start thinking about what are the changes in the recipient's, the host, immune response to the donor microbiota. I think this is maybe where the money's at and trying to understand the immunologic changes here. Is there a specific UC phenotype that really responds to MTT? That's something our trial was too small to figure out, but are there certain people that we could select from the beginning to say this person is likely to respond better? And then really, could MTT be a clinical adjunct to the standard of care? If we look at what's called the net remission rates of all of our studies, meaning taking everyone from a clinical trial that was screened and given a clinical trial drug, and then looking at them at 1 year, we actually see that our net remission rates in IBD are quite low, ranging from 16 to maybe 34% at best. So that's pretty discouraging. So there's clearly a need for, I think, adjunct therapies. And I personally believe that this could be one of them. And so, as Christy mentioned, we're partnering with Achieving Church together to fund a larger trial to look at this. And our goal is to actually look at 120 patients and include endoscopic outcomes, because that's one of the things in the scientific community. Symptoms are great. We want to improve symptoms, but we know in IBD symptoms are multifactorial and are not always inflammation. So we do need some hard endpoints to get changes in inflammation. And we're moving along. Our protocol is written, and we're in the process of getting all the regulatory approval and anticipated to start in 2026. Very exciting. The trial will take 3 to 5 years to complete, but we're very, very excited to keep moving forward with it. What about Crohn's disease? So I'll start by just saying there's a lot less data for Crohn's disease and the microbiome and MTT or FMT therapy. Couple of reasons. One, Crohn's is just a much more heterogeneous disease than ulcerative colitis. It has 3 major locations that it affects, and it's not the same in anybody, but the ileum, the end of the small bowel, the ileum and the colon, and sometimes in some people, it's just the colon. In addition to the different locations that it can affect, it has 3 different phenotypes, which are inflammatory, causing scars, or penetrating, actually causing what we call fistulas, which can lead to all kinds of complications. So very, very different disease than ulcerative colitis. So we started a couple of years ago looking at a very focused form of Crohn's disease, people that had what's called an ileocecal resection. So this makes it a more uniform population, and it means that the inflammation is actually removed, taken out. Now, many people, the inflammation does come back, And in fact, inflammation returning at the surgical site is the rule. And we know that the postoperative Crohn's disease is very closely tied to the microbiome. CD recurrence is actually contingent on the microbiota. There's been studies that show if you actually divert the fecal stream away from a surgical site in someone with Crohn's, the Crohn's doesn't come back until you get that fecal stream and the gut bacteria there. There's pretty good evidence that antibiotics after surgery can reduce the short-term Crohn's recurrence rates. And we know that certain bugs in Crohn's at the time of surgery can predict if Crohn's comes back. So there's a clear association between gut bacteria and Crohn's around surgery. We looked at patients from our clinic who submitted stool samples and compared them to healthy donors. And one of the things we found is that cutting out the intestine does not get people to look back to a normal microbiome. So if you see the healthy group kind of is on this, what we call Shannon Diversity Index is around 4. And we see that people who with Crohn's who have not had surgery are low, under 3 on average. Once they get surgery, there's a little bit of improvement in their gut bacteria diversity, but not a substantial improvement. And the same thing with this other way we look at the gut bacteria called the Cow index. So ultimately, having a resection does not restore normal bacteria. And it doesn't matter if the Crohn's has come back or not, which I think is very interesting. So people who had inflammation with Crohn's still had similar amounts of dysbiosis as people without. So looking at postoperative Crohn's disease, there's a couple of challenges that we had to think about. One is how is our MTT formulation going to impact engraftment in the small bowel? Because this is often a therapy that we think of as colonic bacteria, but we know for Crohn's it's essential to think about the small bowel before the colon. And it's unclear what the loss of the valve between the small bowel and the large bowel means for this therapy. So our first step was to do a small trial looking of capsule administered MTT material versus colonoscopy administered MTT material to see if we saw any difference in engraftment. So we gave everybody basically one dose at baseline and got a colonoscopy before and 8 weeks after the MTT. And we actually very encouragingly saw that regardless of the route, there was about a 40% engraftment rate. So similar to what we saw in UC, that with this therapy we can get about a 40% engraftment rate, and this was true also in the ileum. We didn't see any major trends in engraftment with endoscopic inflammation. Interestingly, this was not a placebo-controlled study, but we did note that everybody who got MTT had a decrease in their symptom score over time. So that was encouraging. And that actually persisted up to 16 weeks. We also saw non-significant trends towards reduction of inflammation on colonoscopy. In science, we get it's very important to have show significance in a findings to make sure that we're distinguishing the signal from a noise. This did not quite reach that threshold, but it's a step in the right direction, and we weren't trying to look at this. So I think having more people in a study like this, we might be able to see actually a signal. So from our first study in Crohn's, we concluded that the capsule administration of MTT results in good donor engraftment comparable to a colonoscopy in patients after an ileocecal resection, and that any form of MTT seems to, again, like ulcerative colitis, lead to a short-term improvement in symptoms. But as with any trial, we end up with more questions than we have answers. So one, I talked about the heterogeneity of Crohn's disease, and we really need a better understanding of how the gut bacteria therapy interacts with Crohn's of the ileum versus Crohn's of the colon. We also, don't really have a good sense of in Crohn's, where do we want the bacteria to be released? If we release the bacteria in the colon, that can repopulate the colon bacteria. It kind of makes sense for ulcerative colitis. But in Crohn's disease, it's a little bit more of an immunologic disease, and potentially releasing the bacteria in the small bowel will change the immune response, hopefully for the better. And lastly, and one of the things that I think is really interesting, and we're starting to think about and plan for doing, is could we pair this therapy with a surgery? So have someone undergo surgery for Crohn's to reset the bowel, to reset the inflammation, to remove it, and at the same time reset the gut bacteria. In a way, almost like going back in time to before there was inflammation in some ways. We can't change the genetics, but we could, at the time of surgery, change both the damaged gut and the gut bacteria. And so these are some things that we're thinking about as we're starting and planning our next Crohn's trials. So one, we did receive a large grant from a Helmsley Charitable Trust and also support from Achieving Cures Together to make the product for a new study in Crohn's. This is looking at answering a few of those questions I talked about. Is there a difference in where we release the healthy bacteria? And is there a difference based on where the Crohn's inflammation is? We're conducting this study at 6 centers nationally, and we've actually already started currently enrolling. So we've randomized the first few patients and really hoping to ramp up our study recruitment in 2026. So I think we'll start to get the answer to some of these questions as we are complete this study over the next few years. So our Crohn's conclusions, well, in general, our conclusions are that microbiome-based therapies are an early promising signal for improving symptoms in people with UC and potentially inflammation. Microbiota-based therapies may improve symptoms in Crohn's, although understanding the impact of the disease location is a current big unknown. So does it improve inflammation in the ileum? And the mechanism of benefit in IBD is really unclear. It doesn't seem to be related to engraftment of the donor microbiome, but it seems to be some other pathway, but it does seem that there's a signal. That is all my prepared slides that I have for now. I would love to get some feedback and questions and be able to take some time to answer some questions.
Great. Well, thank you so much, Dr. Vaughn. We do have some questions that are coming in through the Q&A here, and so we'll get started with those. So the first question is, how can us GI sufferers find a doctor who will do an IND and help? GI doesn't always fit into the 80% of teaching hospitals or clinical trials looking for help.
Yeah, that's tough. I mean, I think what I would recommend for that is talking to your doctor and saying that you want to pursue a microbiome-based therapy and then looking nationally for someone who will. I mean, the unfortunate truth is, well, I'm sorry, this is not an unfortunate truth, but the truth is that the reason this therapy is not available is because we don't fundamentally know that it works. And I always have to remind people that I hope it works. I believe it works, but do I know it works? I don't know. And in order for us to know it works, we do need studies. I don't think this is a panacea. I don't think this is a cure-all. We have seen um, studies in irritable bowel syndrome that have not shown any signal of benefit, which is very interesting. And so, unlike C. diff and inflammatory bowel disease, the current data for IBS is not promising. So, I think it's important that we are aware that that the reason this is restricted to clinical trials and not just tossed around is because it may not work in everybody, and there could potentially be risks. But ultimately, I would say, talk to your doctor, say that you want to explore this, work with your doctor to find clinical trials, use clinicaltrials.gov, University of Minnesota has Study Finder, or just, Google and find it. But single patient INDs, one-offs are not always the right thing, but they may be in a certain case, but it's very nuanced, very nuanced.
Thank you. Second question is asking about the protocol and kind of how you determined that 8-week treatment protocol, and just curious about how you decided upon 8 weeks for treatment for UC, and then also the Crohn's. Kind of what were the determining factors in deciding the treatment length for those
Yeah.
studies?
So 8 weeks, couple things. One, to be completely honest, is funding. I mean, right? We these are this is all money, and this all takes money to do. And so 8 weeks is what we thought was feasible for the study size. Two, in inflammatory bowel disease, 8 weeks is kind of a very common what we call induction study. And so in IBD treatment, we think about one, inducing symptomatic remission and then maintaining symptomatic remission. And so another way to kind of think about that question is, why are we only studying induction and not maintenance? And the reason there is money and just not enough data yet. We don't know if this is something that should be taken every day indefinitely or after an 8-week period. Is this something that could be, done once a month, once a week, or just as needed? So the maintenance question is very, very interesting, but we don't have enough data yet. So I would say there are people looking at maintenance, and I think it's a very interesting question. For now, though, the most of the data looks at induction, and that's just kind of the standard way we've always studied IBD.
Thank you. Yeah, that sounds great. The next, it looks like a comment just of UC and DIY FMT. And so I don't know if you have any comments
Yeah, I
on
do. And I think, I would encourage people not to do that for a couple things. One, I think from a scientist point of view, that's great that they did great, but that information is not usable to the rest of us. And it would be much, much better if those positive experiences were aggregated and helping to advance the science so that this could be um, um, something that is for everybody, right, at the bedside. Now that's not always possible to be in a clinical trial. There's a lot of logistical factors, but I would always encourage you before you DIY to really, really try to be involved in a clinical trial. Two, there is a lot of donor screening, and there are reports of serious infections that have been transmitted in immunocompromised people. So if the screening is not done properly, I mean, there could be bad outcomes. So it's great that in those two cases everything went well, but I certainly do not recommend in general DIY. Much, much, much prefer to have people being done in a structured, organized way with, doctors doing the appropriate screening and monitoring, and then also collecting that data so that we can use it to ultimately make this a therapy that is available for everyone.
Thank you. The next question is Dr. Adams at Arizona State University is doing research on microbiota transplant therapy. Is this the same research that you're conducting?
Yep. So yeah, ACT supports Dr. Adams, and he does fantastic research in autism, and it's a really, really exciting. And fundamentally, I would say this is very, very similar. Yeah, we're using the same type of products. There's a little bit of nuance here and there, but in general, yes, this is the same thing.
Great. Next question. What possible translational relevance might this have for pediatric patients who have had ICR and NICU and now have possible ulceration? Budesonide is used and calprotectin is still 420. No history of IBD has been made yet.
Yeah, I mean, so I think it's very interesting, right? So NICU implies, someone who's very young, probably under one. And we know that there are certain GI conditions. I mean, I sometimes talk about probiotics, and one the one disease that probiotics really, really helps with is necrotizing enterocolitis. That is a terrible, terrible disease, but probiotics can help prevent and sometimes treat that. And so I think potentially for other things in the NICU that are involved in bowel resections, that could be the case. And certainly I think that question has a couple different components. One, it seems possible that this may be early onset Crohn's. Why is there a surgery in the first place? And if there's a surgery and a recurrent ulceration, what's happening? And so, I can't really give any clinical input on that. That's a complex situation,
Mhm.
but I think, yeah, fundamentally, I think we're going to see that a lot of these, we already know that certain pediatric diseases in the NICU are driven by gut
Mhm.
bacteria. I mean,
Mhm.
right now, there's not really a way to clinically do FMT in that situation, but I think it's very reasonable to think about that, yes, the gut bacteria could be driving some of that. Very interesting.
Thank you. Next question is regarding where the FMT was sourced. So, question, was the FMT sourced from open biome or local donors?
So the University of Minnesota has our own donor screening program, and so all the donors are in Minnesota, and they have to be able to come for screening. And so the Microbiota Therapeutics program it does all the sourcing, so it produces all the FMT material.
Great. And then one question about the Crohn's trial. To participate in the Crohn's trial, does the patient have to stop taking Stelara?
No, so most of the trials that we do, people need to be on stable medications and demonstrate that there is active inflammatory bowel disease on their medications. But we actually feel very strongly that this has the potential to be at least complementary. And so no, you absolutely do not have to stop taking your medications. So if you're thinking about this trial, please reach out. You can find us from clinicaltrials.gov or Study Finder at the University of Minnesota. And if you just even if you're not interested, but you just want to learn a little bit about it, or maybe send it off to a friend, definitely look into it. But no, 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 you do not have to stop your drugs for most of these IBD trials.
Great. And then next question, do you check the patient's microbiome prior to therapy in the clinical trial?
Yes, absolutely. Yeah, we typically try to get 2 or 3 stool samples before therapy so that we can establish a baseline and make sure there's no variation. And we want to make sure to get those samples, before there's any bowel prep, which can disrupt the gut bacteria or without any recent antibiotics, things like that.
And then we have another question just in regards to the FDA and current regulation for FMT, and if you have any recommendations as to help with the process of FDA approval and those and that whole process in terms of getting FDA approval for FMT.
Yeah, so I mean, there are 2 approved microbiota-based products, which is great. I mean, there is actually nice to see that there's a pathway to approval. The products are both approved to prevent recurrent C. difficile infection. And so that's fantastic. I think that's a huge success story from, decades of research on this to getting an approved product. I think that, the most important thing for FMT in terms of it being an open sourced type therapy is one, making sure that the FDA is aware that there are gaps, so pediatric C. diff and severe fulminant C. diff, and so kind of making sure that there's still noise in the FDA's ears through public comments or on letters to your senator that there are these gaps and that the FDA's enforcement discretion, while it can be narrowed because we do have some approved products in certain for most of C. diff, that there are still some gaps that I think FMT has a role for. But beyond that, it's really important that things are done in a way to promote the science, to get patients into clinical trials, to ultimately get the data we need to show the FDA to get approval for a specific indication. So it's not really about petitioning the FDA for a lot of this stuff. It's about supporting research and if you have somebody who has Crohn's, letting them know that there's this trial and there's a bunch of different sites that they could be recruited at. But that's really the way. I mean, again, I think it's just such a success story that we have approved products that are fundamentally very similar, if not, some people can argue they're the same as FMT, but very similar to FMT. They're microbiota-based products for recurrent C. difficile, so that's great. But we need more, and we need more indications. So.
That looks like that's all of our questions for tonight. We first just want to thank Dr. Vaughn for taking the time to be with us here tonight and to share the remarkable progress that you're leading in IBD research and the care that you provide to each of your patients. We also want to thank everybody who joined us for the webinar tonight. If you do have a question that didn't get answered, feel free to email us at info@achievingcures.com. We also, do look to host future webinars. So if you saw a health condition that is currently being investigated by microbiota transplant therapy and are interested in learning more, let us know, and we'd love to take that into consideration as we set up future webinars. Again, reach out to us with any questions at info@achievingcures.com. And thanks so much to everybody for joining us tonight.
Thank you so much, Christy. Take care.
Thanks, Dr. Vaughn. Have a great night.